We welcome you all to Talk the Talk. My name is Janine Steen.
And I'm Tony Ann Antoniato,
the Masters of Myofunctional Therapy.
Together we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving. Hello, and welcome to this episode of Talk the Talk. I'm your host, Tony Ann Antoniato, and today we're joined by Dr. Germán Ramírez, a pediatric dentist and airway-focused orthodontic educator, researcher, and author known for his work on early malocclusion, craniofacial growth, mouth breathing, and the connection between oral function and pediatric sleep-disordered breathing. Dr. Ramírez's work challenges the idea that orthodontics is simply about aligning teeth, and rather about growth, breathing, function, and early intervention. Thank you, Dr. Ramírez, for joining me today.
Thank you, Tony. And it's a pleasure to be here, and very well done with all this work trying to spread the word for the parents, for the professionals.
Absolutely, definitely. If we can kind of jump into a little bit more about you and your work and why and how you became so passionate about early orthodontics and how oral function and malocclusion and airway are all tied together.
All right, this started a long time ago when I was in my country, or in Colombia. When I finished dentistry, and normally we leave the school and we understand at that moment after leaving the school that we can repeat whatever we learn in the school or to move forward and learn more. And at that moment I realized that I need nothing and I need to study more. So I decided to do the specialty in pediatric dentistry because I was thinking that if we start preventing things earlier, we can prevent. At that time, I was thinking about cavities and how to manage with the kid all these issues. But when I went to my pedo program, I was very lucky because I had a professor that started teaching me about functional appliances. And I said, this is very interesting because I was seeing malocclusion in kids. And everybody was telling me, wait. And I was saying, wait for what? If the child is growing at this moment, if I have a 5 years old, I see in 6 months and it's a totally different child. If I see when he's 7, it's another child. And if the child is growing, that is the best moment. So this professor just mentored me and introduced me to treating early. And then when I finished my program in pediatric dentistry, I continued interested in this area, and I had the opportunity to meet another professor in Brazil that she told me a lot of things, how to start treating really early malocclusions, how to treat in primary dentition, based in the Professor Planas philosophy from Spain. So I started treating early, but when I was treating the patients, I wanted to understand how was the body response to all these appliances that we were doing in the mouth and all these techniques that we were using. So I decided to do a little bit of research, and I moved to Australia, where I have the opportunity to do a master in oral biology, understanding a little bit the tissues, and then to do the PhD in oral biology. So I understood how the mouth works. And understanding how the mouth works gave me the opportunity to treat the patient better and to treat the patient earlier. And I started realizing that there was a lot of correlations between mouth breathing, oral dysfunctions, and giving all these symptoms, how they associate with the sleep and breathing disorders. So I did a second master about craniofacial growth and development, craniofacial pain and sleep and breathing disorders. But I didn't want to treat, I did the master focusing in how to bring that information to kids. and to develop that. So that's what I am doing today. I am focusing in developing the craniofacial structure and at the same time to correct all the oral dysfunctions, because for me is very important, is basically 50-50. Me as a dentist, I can work with appliances and correct the structural problems. I need the support of the myofunctional therapists to correct the oral dysfunction. So what I am doing with the appliances basically is 50% of the results, and the myofunctional therapist work is 50% of the results. So putting all together, we can get a very successful and stable treatment. I was just minutes ago, before we started this, I was reading a paper published in the Journal of Orofacial Orthopedics in 2011 by Professor Seaman, and she was demonstrating there that one of two kids have a problem with a narrow maxilla, crowded teeth, and that is associated with oral dysfunctions. So all these kids are presenting oral dysfunction. So we need to treat both. We need to do a full diagnosis, what's going on. And then when we understand what the problem is, we can start at any age. If you ask me today, what is the best technique to move teeth? Immediately I'm going to respond braces, right? If you want the teeth perfectly aligned, you should use braces. If that is your goal, is to use braces, right? And I don't argue that, right? If you are looking for aesthetics, that is your option. But you have to think that the teeth are connected to the bone. The bone is connected to the muscles, and all of them are guided by the nerves. So I have to put all this in context and all of this working together to get a better structure, to get a better foundation. So in that way, the teeth can accommodate in a better position. And the results are going to be more stable, because let's think that you are building a house. The child is the foundation. Whatever we have in the child is the foundation, what is going to happen in the adult, right? So we need to develop that structure, that we create the base on the bones, that all the adult teeth can come in the mouth, right? At this moment, we are not talking about it. They are going to come perfectly aligned with a beautiful smile. We are talking that they can come to the mouth, and the child doesn't have to lose teeth in the future to accommodate the others, right? So that is the major goal if we start early, to correct all the structural problems, but knowing, and the evidence is showing us, that when you have a structural problem, it's always associated with a functional problem. So I need to correct the functional problem as well. So that's why we have to do the full diagnosis. We have to do the evaluation of the structural and functional problems and start correcting those problems at an early age. Because if you are a mom or a dad, right, if you are parents, and you see your baby, your little baby when it's born, right? And you see that baby 1 month later, and it's a different child, right? And you see that baby 6 months, and it's a totally different child. It's growing like crazy. So why I don't do the things correctly from day one? And when people ask me, when is the best time to bring my child to you? I say, when you were pregnant, before your baby was born, because I need to educate you to do the things correctly, right? And in that way, you can guide your child and do those steps at the very beginning in a correct way. And we can educate the parents in how to do a correct breastfeeding, what happens if they have a tongue tie or a lip tie, why it's important to release those tethered tissues, that they don't affect the growth and development in the future. How important it is to prevent mouth breathing, how to educate the baby to continue being a nasal breather as it should be. And all those steps are going to create a foundation for a good maxilla and mandibular development, right? If we see a problem in the primary dentition, I normally explain to the parents, we are going to correct the position of the jaws. We are not going to correct the position of the teeth, right? We are going to stimulate the growth and development. Your child is growing like crazy at this moment. So they understand that it's important to intercept any problem that we have at that moment. And then that kind of facial growth and development and that functional part in the mouth that is deviating from the normal can come back to the normal and the child can continue growing and develop. Obviously, and we have to explain ourselves to the parents. It's not a treatment that I am going to give you a pill and you're going to be better tomorrow. Your child is going to be better tomorrow, right? Your child is growing and developing, so we need to guide that. And the growth and development is going to go until your child is 13, 14, 15 years old. So I have to follow your child. It's not a treatment that I'm going to put an appliance and then it's done. It's totally different to the concept when we go to the orthodontist and the orthodontist is putting the braces and aligning the teeth. It's a totally different concept, and we need to educate the parents to understand that.
Right.
It's a long process. And it's like when you take your child to the pediatrician is frequently seeing your child during the growth and development at the beginning, and then is following your child until your child is 15 years old and say, all right, now you can go to the family doctor. We have that similar way. We have to start the child very early to guide the craniofacial growth and development, then to follow the child. And at 12, 13, 14, all right, now you can go to your family dentist and continue to regular checks. But everything is much better than your mouth. All right, if at the end, every tooth is not in a perfect position and you want something more aesthetics, all right, you can do a simple treatment with braces or aligners, right? But we prevented the tooth extractions. We prevented a lot of health issues that can develop because mouth breathing, like sleep and breathing disorders, like sleep apnea later, the patient becoming an adult, a lot of behavioral problems in the adolescent, because we know that mouth breathing and sleep and breathing disorders are related and associated with behavioral problems. There is a lot of evidence in the literature showing that. So we are preventing all of that. And it's worthy. I don't know if I remember when I started my training in dentistry, I went the first year to dental school, and one of my teachers said, you are one of the most important professionals because everything in the body enters through the eyes and through the mouth. So you have a big door that whatever is entering through this door is going to affect all your body, right? So it's not as simple as use making nice teeth. It's what we are working in the mouth and how we work to make that mouth better structurally and functionally, that the rest of the body is going to benefit of that.
Right.
So that's why I'm a little passionate about all of this, and particularly when I work with kids and I see them growing and getting better, that's really rewarding.
Yeah, truly changing lives. And I really appreciate that comparison with the pediatrician and, aligning it like that. I like that. It's a great way to explain it to parents. But yes, it is a journey. And what we're doing from a myofunctional and from a speech perspective is a journey too, many of the times. We get that question very often from parents, how long will this be? And especially when it comes to myofunctional therapy, and especially when they're going through orthodontic treatment, we're saying like, we got to continue to change this function as the structure is changing. So we have to work hand in hand and work together to have the long-term success that we want for every single patient.
Yeah, that's very important. Whenever we are correcting any structural problem in the mouth, we have to correct the functional problem. So we have to work together.
Yeah.
There is no way. If we are only treating one part, we are doing just partial results, and it's not going to be stable.
Yes, agreed. When you have a patient who is in primary dentition, what are some things that we want to see? Like, I know we talk about having spacing between every single baby tooth so that you know there's enough room in that jaw and in those jaws. But what else are some things that we can look for to make sure at that 3-4-year-old range that things have developed the way we want them to?
Normally, when I start looking at the mouth of a child in primary or in mixed dentition, but particularly in primary, it's important to start thinking how is the full development. So basically, we have to look, yes, spaces in primary dentition are important. And one of the things is that people are thinking like in adult dentition, and the child is different. Right? It's not the same. For example, talking about spaces, when we have the adult teeth, we don't want spaces, right? Yeah. That is normal in the adult dentition, but in the baby dentition, in the primary dentition, we want spaces between, and the more spaces we have between the teeth, the better, because we are going to have a good, but that is showing us how the jaws are developing transversally. So we don't want to see teeth together in primary dentition. So when we see teeth together, or ever we have children that they have the baby teeth crowded. So that is showing us that we don't have a good transverse development. And in most of those cases, could be because the tongue is not resting on the roof of the mouth, not resting on the palate, right? So the tongue, I always explain to my students, the tongue is the best palatal expander. When the tongue is sitting on the roof of the mouth, is pushing. Every time that we swallow, is pushing to develop the maxilla. But the other thing is how the maxilla and the mandible are developing in an anterior-posterior position. Right? And that is important to evaluate in the baby teeth as well, because there is another misconception that in adults, the upper teeth should cover the lower teeth. People say about 20% or 2 to 3 millimeters. And the distance between the upper jaw and the lower jaw on the teeth should be about 2 millimeters as well. That is for the adults. For children, it's different. For children, they should be almost in an edge-to-edge position, right? Why? Because normally the adult teeth, the upper, they erupt a little bit forward, and the lower, they erupt a little bit backward. So if we have an edge-to-edge position in the baby teeth, then we are going to have the correct position of the adult teeth in an AP position, right? So that's another thing that we look forward. The other thing is important that people don't look too much at that, and they look in adults, but they don't look in children, is how high is comparing both sides. If one side of the jaw is higher than the other side, if the child has a cant, right? That is very important. Because if the maxilla is tilted to one side, it means that the child is masticating more on one side. So the child has a favorite side of mastication. So we have to start working on how the child is masticating. And normally, we should masticate on both sides, but it doesn't mean that we open and close and try to chew on both sides at the same time. That is wrong. That is a misconception. Right? When we say that we should masticate on both sides, it's alternating. I should masticate about 10 times on the right side and then moving the food to the left side and masticating, chewing 10 times on the left side. And in that way, we are alternating the side of mastication. Because in that way, we can destroy the food. And we need to educate the child how to masticate. Because you can test yourselves. If you have a dish with pasta and salad, let's say you have pasta and you have green salad, then you chew the pasta and you're going to see that your jaw is moving down and upward, doing vertical movements. And you can destroy the pasta very easy just with that simple movement of the mandible. But when you grab the green leaves and you put in your mouth, now you have to start moving your jaw to the side to tear off the fibers of the leaf. Because if you maintain only a vertical movement, you cannot destroy the leaves. Right? So you have to start moving. And when we start moving the mandible to one side, is when the mandible and the maxilla is going to respond with growth. And that is going to stimulate growth on both, on the mandible and the maxilla. And then I stagnate to the other side to finalize the destroying. And then I'm going to stimulate and I'm going to produce a symmetrical development of the maxilla and the mandible on both sides. So we need to start educating the parents. And in that way, they understand that a soft diet, then you are doing vertical movement, but a fibrotic, harder diet, you have to move the mandible and destroy to be able to destroy. So, for example, if you don't have an edge-to-edge position, but you have a big overbite that people call an overbite, right? The child can do only vertical movements. They cannot destroy the food. They can, so they don't like because they cannot destroy the food and they cannot swallow. For example, they have a piece of meat in the mouth, a piece of beef, and they are chewing, and then they take out the beef of the mouth because they cannot swallow, because they feel that they could destroy. So the parents immediately start thinking, oh, my child doesn't like the beef. And they start grinding the beef, so the child doesn't have to chew too much. And when the child reduces the chewing, it's reducing the growth and development. So those are concepts that we need to start looking at from primary dentition and educating the child, not only to breathe through the nose, to accommodate the tongue on the roof of the mouth, to do a correct swallowing, but also to do a correct mastication. And by educating them, we are going to correct, because every function, nasal breathing, correct swallowing, and good mastication is very important for the development of the maxilla and the mandible. And the other thing, that when we are developing the maxilla and the mandible, we have to think that we are developing the airway. Because when we develop the maxilla, the upper jaw is the roof of the mouth, but at the same time is the floor of the nose. So whenever I am developing the maxilla, I am developing the nose, and the child can breathe easier, right? Because it is easier to pass the flow. When I am developing the maxilla, I am giving room to the tongue to sit on the floor of the mouth, and the tongue at the back, the base of the tongue, is part of the airway because it's limiting the oropharynx. So whenever I have the tongue backward, the patient is feeling that it's shocking because the oropharynx is closed, right? It's reduced. And in that way, when I am creating all this function better in the mouth, all this structural better in the mouth, I am giving a better airway to the patient. I am not treating the airway problems. I am not a physician. I am a dentist. But by producing this development, as the maxilla and the mandible and the tongue indirectly are part of the airway structure, so I am going to give a better airway to the patient. And that's what we see, that when we are doing all these treatments, many patients are reporting, oh, my child is sleeping better, my child is feeling better, my child is behaving better, because we are creating a better way, right?
Yes, definitely. We see it all the time, over and over. And, some people out there are still going by this more, oh, they have too many baby teeth still, wait until they're older than 7. Do you think why that is still happening?
Yeah, because it became a normal saying that you have to wait for the age of braces, right? Yes, but totally respectful. You have to wait for the age of braces if your goal is to give your child a beautiful smile. If that is your goal, if you are not thinking about anything else, that is your goal.
Right.
Totally acceptable, right? But if your goal is to give a better health to your child, to give a better sleep to your child, a better structure of the jaws, to prevent the risk of having to extract teeth in the future, to reduce the number of the teeth, and preventing sleep and breathing disorders as an adult, you have a big opportunity of starting early to create a good foundation of the maxilla and the mandible, so everything can develop better in the mouth. So it depends what is the goal of the parents, right? If I see a patient and they say, no, what I want is you to align this canine, I say, probably you are in the wrong place, because you are not understanding all the things that I am explaining to you, and I am seeing in your child, right? The parents, I am explaining to look at your child, is with the mouth open all the time, he breathing to the mouth. If you are reporting that he's snoring, you are reporting that he's restless sleep, if the child is feeling tired in the morning, you can see the face of the child, and the child at 10 a.m. is in my office and the child is almost falling asleep. And the parents are telling me, but we want to align these teeth because the teeth are crooked. I say, all right, you are in the wrong place. I am trying to show you behind what's going on. But if that is your goal and that's what you want to pursue, all right, I think you should go for braces and align your teeth. But if you want us to treat all of those issues around, all right, we can help. So that is, at the end, is your decision what you want to do, right?
Right. Yeah. And a lot of the times the parents don't know because, they don't know what they don't know. And they're going off of what the pediatrician maybe has said or their regular dentist has said. And then I find that when I start talking to them about, the size of their jaws and how their tongue is resting and their mouth breathing and how that could be linked to their snoring and their behavior issues during the day, you see that light bulb go off in the parents and they're like, wow, like how did nobody ever tell me this before? This makes so much sense.
Exactly. And that is basically one of our major work when we are seeing a patient, is showing them all the problems that they have. And then they can understand how it's affecting the general health and how we can help. And some people think, oh, but with those simple exercises, or well, is that appliance is going to help with that? And we need to explain them how the exercises and the appliances are going to work, because basically the appliances are designed to stimulate the growth and development. And one of the things that is we have to have clear is that, and that's why I call Myofunctional orthodontics my philosophy, because we are working, when we say myo, we are working with the muscles, right? And it's something that is very simple to understand. Because, for example, if you want to have a healthy body and a healthy skeleton in your body, what do? You go to the gym and you are working with your muscles, right?
Yeah.
Because when you activate your muscles, the bone, the skeleton is going to respond and it's going to become stronger, right?
Yeah.
So in the mouth is the same. I need to activate all the muscles around the mouth to make them working properly, and they are attached to the maxilla and the mandible, and then the maxilla and the mandible are going to become better. They're going to become wider, are going to become in a better position, right? So it's driven by the muscles. It's not that I'm going to put an appliance to hit the bone and to make the bone grow, right? And that's what people, for example, like are thinking that happen when you put a palatal expander, you are putting a palatal expander and you are breaking the bone and you are making the bone wider, right? The maxilla wider. But what happened? If I don't educate the tongue to go to the roof of the mouth, there is not going to be support for that maxilla, and the maxilla is going to collapse again. Right. So I need the muscles because the tongue is an organ that is composed by 18 muscles. So the tongue has the possibility of support all that and to maintain that. But if I do the palatal expansion and then I try to align the teeth in that space, and then I don't have the support of the tongue, and the patient continue breathing through the mouth, and the tongue is on the floor of the mouth all the time, everything is going to collapse. And then in the future, the patient needs another treatment because everything is going to relapse, right?
Yeah.
So again, that's why it's very important we have to educate the parents. Yes, your child has to use the appliance, but at the same time, your child has to do the exercises, right? Because, for example, I give a myofunctional appliance that normally they're bulky appliances.
Okay.
When you put it in the mouth, I always explain to the patient, you are going to feel in your mouth like a big potato in your mouth. It's huge, right? And when you put something in your mouth thinks that this is food. So what is the normal reaction of the mouth? To produce saliva, to help to destroy that food. So the first reaction of the child is, I feel a lot of water in my mouth. All right. So we need to understand how to swallow with the appliance. And then you have to start, and what happened? You have an appliance that is encouraging you to breathe through the nose. So whenever you try to breathe through the mouth, you are going to spit out the appliance. The appliance is going to come out of the mouth, right? So in order to maintain the appliance in the mouth when you are sleeping, you have to become a nasal breather. And to become a nasal breather, you have to do the exercises.
Yeah,
so
all related.
if you don't do the exercises, then the appliance is not going to stay in your mouth, and then we are not going to get the results.
Right.
So we need to do everything. It's not that you're going to use the appliance and that's it. You have to do the exercises.
Right.
So whenever you tell me that you are sleeping with the appliance the whole night, it's because you have breathing through the nose the whole night. But you're going to achieve that with the exercises. Otherwise, we are not going to progress, right? So I always explain to the parents, your child is going to start using the appliance. Your child needs to use the appliance when sleeping, but your child is going to lose the appliance, right? At the beginning. And if you do the exercises properly and your child starts practicing to breathe through the nose during the daytime, then your child is going to replicate that nasal breathing during the night, and your child is not going to spit out the appliance. And now we are getting ready to start getting results.
Yeah.
So we need to do that together, all that training. Right?
Definitely.
And that's the way to get the results.
Yeah. And, doing that analogy about working out and strengthening those muscles, we say that as well and talk about the fact that, if you only go to the gym once a week, what's the outcome going to be compared to when you go to the gym every day or 5 times a week? We need that same type of consistency that we're practicing these exercises on a daily basis to see the outcomes that we want as well. It's not just like, all right, we did it once, we did it twice this week. We have to be consistent with those exercises as well.
Yeah, for example, people say, all right, I like to walk. All right, you have to walk at least half an hour every single day.
Right.
To get something. So it's the same. You have to dedicate at least 15, 20 minutes every day to do your exercises, and then you will see results. If you do the exercises every other day or once in a week, you're not going to see the results because
Okay.
you are going back. Our brain is overwriting. When we have a habit, let's say we are a mouth breather,
Okay.
we need to overwrite that habit and become a nasal breather. Our brain needs a stimulus every single day of the new pattern that we want. And then after 60 to 70 days, the brain is going to have new connections in the brain to make that habit the new habit.
Right.
So we are not washing out the whole habit and a new habit is going to come, right? We are creating a positive habit. We have a bad habit and a good habit. What we are doing is that basically we are overwriting this new old habit with the new one, and our brain is going to maintain that habit after a while, normally after a couple of months, practicing every single day, right? But what happened, for example, in the case of mouth breathing, the patient have a flu, become very congested.
Right.
So the patient start breathing through the mouth again, and then the bad habit override the good habit again. So we need to practice again the exercises, and then it's going to be easier. It's going to be shorter for that good habit to become back, and then to continue nasal breathing. But that may happen during the life, and the patient has to be conscious that we are going to maintain, and the patient has to continue practicing everything in the right way to maintain that good habits happening, right?
Definitely, yes. And it's, sometimes too, they don't feel like they're comfortable breathing through their nose because they have been a mouth breather for so long. And I think part of that too is training their body to recognize this feeling when you breathe through your nose. It's, slower, steadier. Whereas compared to when you breathe through your mouth, you're getting this bigger gush of air, and they become more used to that. That becomes their normal. And a lot of the times we have to train them on what it feels like to be a nasal breather. And, we do timed exercises where we say you're going to suction that tongue up, close your lips, and sit there for 5 minutes. Once we could do that, now let's move it to 10 minutes and, increase their endurance to help to support that change in the habit as well.
And many parents say, oh, my child cannot breathe through the nose.
Right.
And so we have to show them that, yes, they can breathe through the nose. What happened? If you don't use it, you lose it, right?
Yeah.
So if the child is breathing through the mouth, what happened? There is no air passing through the nose. The air is not oxygen, right? The air is compounded by many gases, and there is water in the air. So the air is moisturizing all the mucosa inside the nose. So what happened? If I am not breathing through the nose, I am not moisturizing the nasal mucosa, and it is going to feel dry. It's going to dry, and when the mucosa dry, I feel my nose totally stuffy, right? I cannot breathe through my nose, right? And I continue breathing through the mouth. But it's slowly I start incorporating air into the nose, and I moisturize all the mucosa. The mucosa is going to feel fresh, and then the air can pass easier through the nose, and the nose is going to start feeling that it's opening. It's not opening because what is happening is that when you have a dry mucosa, it's gonna swell. It's gonna be inflamed. So as the mucosa inflamed, it's blocking the passage of the air. As I start moisturizing the nose, and the patient start humidifying the mucosa is going to reduce that inflammation, and then the patient can breathe easy.
Right.
And another thing that we have to think is, for example, if I have a narrow maxilla, then the structures of the nose is going to be pushed inside,
Right.
and the passage of the air is more difficult. If I have a cant, if the maxilla is tilted on one side, the patient may feel that on one side the nose is blocked, because the maxilla is pushing that side and the
Mhm.
patient cannot breathe well. So again, we have to evaluate how much is structural, how much is functional, and then to correct everything to give the patient a better airway.
Yeah, yeah. Do you tie in like different types of nasal hygiene strategies during their start to expansion to help support them being a better nasal breather?
Of course, yes. We normally recommend, obviously, one of the things when we are starting with the patient with the breathing exercises, we normally to recommend the patient to do one round of exercises before bedtime,
Okay.
right? They're working during the day, but it's important that they do one round of breathing exercises before bedtime because in that way they're opening the nose and moisturizing, humidifying the nose to feel better when they go to sleep and to feel better when they are sleeping with the appliance in the mouth. We recommend also nasal rinses with sea salt water
Yeah.
used to rinse and to again try to humidify because the stuffy nose is normally associated with dryness of the mucosa, and that's giving that sensation to the patient. So we recommend them to do nasal rinses to humidify and try to clear the nose so the patient can breathe through the nose easier.
Yeah. And as you transition patients from mouth breathers to nasal breathers and support their structure, are you noticing changes in children who had enlarged tonsils or enlarged adenoids? Are you seeing positive changes there?
We cannot say that there is evidence showing that there are some reports, for example, from Dr. Yoon, that is showing that when she did the maxillary expansion, there was a reduction in the size of the tonsils and adenoids. There are some evidence coming back. There are reports from the ENTs that saying that we remove the tonsils and adenoids, and there is a high percentage of patients that they relapse to snore and they relapse with the sleep issues after 6 to 12 months, right? And yes, my idea is that many patients go through the surgery, but the patient continues as a mouth breather, right? And the tonsils and adenoids is lymphatic tissue. And the goal of the lymphatic tissue is to clean any toxin, anything bad that may go into the body, right? That's the purpose of the lymphatic tissue. And the tonsils and adenoids are lymphatic tissue. So if I am breathing through the nose, I am clearing a lot of those toxins and bad things when the air is passing through the nose. But if I am breathing through the mouth, everything is coming directly to the tonsils, and the tonsils are going to increase because the lymphoid tissue is like an army. They have to put more soldiers in front to protect whatever is attacking our body, right? So it's logical. I know there is no evidence, and many people can argue there is no scientific evidence to say that, but it's logical that if I start clearing the air through the nose, and when the air is reaching the tonsils and adenoids is cleaner, and the work of the lymphoid tissue is less, they may start reducing, right? So it's nothing. We have observed some patients. We can tell the parents, all right, but it's nothing that I can say, all right, if the ENT is recommending the surgery, I'm not going to say don't do the surgery. That's not my field. That's not what I have to say. And I normally explain to the parents, if the ENT is recommending the surgery, is because they are really inflamed and probably is a chronic inflammation and probably is not going to reverse. So the ENT knows why they are recommending the surgery, right? So follow their advice. But in cases that we see issues, some patients are saying, I feel better, I am breathing easier through the nose, and there is a good result. And definitely, as I said, is because the work that we are putting on the tonsils and adenoids is reduced because now all the tissues in the nose are helping to clear all the air that is passing through. And the other thing that is important, we need to remember that when we are breathing through the nose, we have all the sinuses, the maxillary sinus, the sphenoid sinus, all the sinuses around the airway producing nitric oxide. And the nitric oxide is not only helping to maintain the airway pattern open, but also is an antibacterial. It's going to help to clean of a lot of bad things coming in our body through the air. Is going to help to clean. We don't have that effect when we are breathing through the mouth. So we have a lot of bad things coming in the air, and nobody helping the tonsils and adenoids to clean that air.
Right. Yeah. I was thinking as you were talking about the ENT and sometimes those tonsils and adenoids, being truly inflamed and needing surgery and removal or shaving of them. And when I started in this career, I am in this field about 15 years now. I've seen with my own eyes a lot of changes in collaboration between orthodontists and myofunctional therapists, and knowing, this is a team, we need to do this together. Everything that you were just saying, can't do one without the other. And I wish and I hope that will happen more between the ENT and the myofunctional therapist, because I see what you just explained all the time within my own patients is that they had their tonsils and adenoids removed. Things got better. Now they're not snoring anymore. They're sleeping better. Their mood has changed, and then things relapse. And, I try to explain to the parent that surgery had great benefits for your child, but we changed the structure. We made that airway less obstructed, but nobody showed the muscles what to do now that they had this nice open airway. Nobody told that tongue to suction up and, get to the palate. Nobody told those lips to stay closed, and nobody looked at what the jaws were doing, because they're a, prisoner of those tonsils and adenoids and all that mouth breathing. So I would love to see more of that, standard of care being that collaboration between ENT, myofunctional, orthodontists, and working together there as well.
Yeah, we have to work as a team. Unfortunately, specialties became islands, and everybody is focusing in their field.
Yeah.
Right? We dentists are focusing on the teeth, speech pathologists in speech issues, ENTs in all the structural of the nose and the things, but we don't see how we can collaborate with each other. And when we start working as a team between different specialties, the one who receive all the benefits is the patient. Right. Because now they are seeing that the problem, and most of the problems in our bodies are multifactorial. Right? It's always related with everything is connected in our body. Right? So it is, as everything is connected, every action has a reaction. If I am a mouth breather, then the tonsils may overgrow, and that is affecting the ENT field. If the ENT remove the tonsils, but the myofunctional therapist doesn't teach the patient how to breathe through the nose, that is going to affect the ENT again, because it's going to relapse. And then if I have an narrow maxilla, there is not a place for the tongue to sit there. And then it's going to affect the orthodontist or the dentist or the pediatric dentist who is trying to guide the growth and development. And everything is connected. So we have to work as a team and to understand each other. Unfortunately, many times we are so busy that we say, I don't have the time to do this. But it's important that we understand and start communicating a little bit more between different professionals and to be able to help the patient in a more integrative way. So that is going to bring out the benefits. Yes.
Yeah. Is that, and what else might be some of your hopes for the next generation of orthodontists? What do you hope they understand differently about growth and about function?
All right. One of the things is that in human beings is the most difficult thing to do in a human being is to change. Yes. So we are trying to put a little grain of sand on this field all right? And we will continue adding little grains, and hopefully in the future, probably the future generations understand better that we need to communicate and that everything in the body is connected. And it's not that we have to correct one thing and get results, right? We
Right.
have to correct all the factors involved, and we need to understand what the problem is. Once we understand what the problem is, we are going to realize that there are several things that we have to correct, and that I, as a dentist, can correct probably 2 or 3 of them, but I need the myofunctional therapist to correct another thing. I need the ENT to correct another thing. I need the osteopath to correct another thing. So and I need the lactation consultant to correct another thing. So in that way, when we understand what the problem is and all the factors causing that problem, then I can invite all the professionals that may help to produce a better results. And hopefully in the future, the medical schools, the dental schools, the SLP schools, and all the schools involved start communicating between them, because we are receiving the information from those schools. And if they don't know how to communicate between the other schools, then we are not prepared to talk with the other professionals and with the other specialties. So, things has to change from the core, and definitely the community, the parents, play a big role, because if the parents go to the dentist, go to the speech pathologist and say, all right, I see that my child is with the mouth open all the time or breathing to the mouth when he's sleeping, and I know that could be caused because there is a problem with the growth and development of the jaws, and I want to have myofunctional therapy for my child, then that is going to start pushing the professionals to go and understand what's going on, right? And not saying, no, that doesn't work, right? When the parents start pushing, that is going to be a big wave to change the professionals, right? And today, yes, I know with the social media, we have a lot of parents trying to do that, and it's really good. Sometimes it's too much information that they may not understand, but if they grab a little bit what they understand and they push the professional to help them in that way, that is going to change the next generations as well. Okay? And we as a professionals, we need to continue educating our colleagues and trying to explain them what we need to do. That's what I am trying to do, having educational courses for my colleagues, inviting them to come to the courses and to understand how to work together with myofunctional therapies. We train the dentists in understanding the importance of myofunctional therapies and how they need to work as a team to produce better results, and also explaining them that we need to start as early as possible, because we are not working in the position of the teeth. We are working in guiding the craniofacial growth and development and correcting all the oral dysfunctions of the patient to produce a better result and a more stable result in the future, and preventing major problems. Right? So I think we have a couple of minutes. If you allow me, I can share a little bit of information for the people listening to this podcast. We have a course here in Toronto. It's starting in May. We have 3 modules. One is in May 15, 16, and 17. It's 3 days that we dedicate to every module. In that course, we have module 1, module 2 in June, at the early June, and module 3 at the end of June. And in these 3 modules, I explain to my colleagues, the dentists, all the philosophy, all the different concepts that to understand craniofacial growth and development, and how to guide the craniofacial growth and development, I explain them all the techniques that I use to guide the craniofacial growth and development, the different appliances that I use in different cases, and how to combine them. And also, I am a very lucky guy because my wife, Amdola, is a myofunctional therapist.
Oh,
So
very
she
nice.
explains also, she trained the dentists and their staff how to work with myofunctional therapy and how you can integrate myofunctional therapy in your office. So it is a very well-received course. We have been doing this over the last probably 8-10 years.
Okay.
When I invite my colleagues, if you want to visit Canada and come to Toronto, you are more than welcome. Here you have the information. You can take a photo of the QR code, or you can go to our website, kidsmalocclusions.com. We have all the information there, and we are welcoming you, and I will train you whatever we do in the office in the early intervention and how to integrate myofunctional therapy in all the treatments. We will teach you, so you will be able to do whatever I do in my office in the same way.
Amazing, amazing. And Dr. Ramírez, you truly are changing the future of orthodontics and that next generation. So we thank you so much for all your coursework and books you've written, and you've done so much in this field. And as a speech language pathologist and not in the same field as you, it's still so valuable. You're helping to change our field as well. So I do thank you so much for all of your commitment and passion in this area as well.
Thank you very much, Sonia. It was a pleasure to talk with you. Yes, anything that we can add to help the patients is going to benefit everyone. Thank you very much for inviting me. It was a pleasure to be here.
Yes, it was such a pleasure to have you, and I look forward to seeing you at the next PANI conference here on Long Island.
Yeah, I will see you there.
Okay, thank you so
Thank
much,
you.
Dr. Ramírez, and enjoy the rest of your day.
Thank you for joining us on this episode of Talk the Talk. We hope it was enjoyable and educational and further supports you both personally and professionally. For more information, please check out our Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk. And don't forget to check out our tongue training appliance, SpotPal, to help with tongue thrusting, thumb sucking, snoring, TMJ, mouth breathing, and so much more. Visit thespotpal.com.